Good morning, everybody. My name is Craig Coopersmith, and along with my friend Daniel DeBacher, we're the co-chairs of the Surviving Sepsis Steering Committee. We will be co-moderating this session. Our first speaker will be by video because due to world events, he was unable to get here this morning. Our last speaker, due to world events, took 48 hours to be with us this morning. So our first speaker will be from Walid Al-Hazani, who is the methodologic chair of the 2026 Adult Surviving Sepsis Campaign.
Hello, everyone. Due to unforeseen circumstances, I wasn't able to join you in person. Nevertheless, it's a great pleasure to be here virtually today. An exciting day. The Surviving Sepsis Campaign 2026 guidelines are being published today. So let's go through the methodology over the next 15 minutes. These are my disclosures. None are financial. They're mostly academic. The evolution of the Surviving Sepsis Campaign guidelines over the years is quite astonishing. It's one of the examples in the critical care field where state-of-the-art methodology has been adopted over the years. The guidelines started in 2004 with the expert-based consensus, a smaller panel size and fewer recommendations. But over the years, as the number of recommendations and clinical questions that need to be answered increased, the complexity of the guideline methodology also increased, including the adoption of the GRADE approach, the evidence decision framework, and other approaches. And now in 2026, we're talking about a panel size of around 70 and more than 100 statements in the guideline, and adopting the most up-to-date methodology for guideline development. And that's the purpose of the talk today, is to discuss these approaches. The guideline organizational structure involved the leadership. The leadership involved the chairs and co-chairs, the methods lead, the conflict of interest chairs, and the low-middle income country leads as well. The guideline working group, the panel was distributed across 6 subgroups, focusing on separate domains. There is a systematic review, dedicated systematic review team working with the guide group, the patient family representatives. They all worked in harmony, following a clear methodology and protocol for guideline development. The Surviving Sepsis Campaign leadership did a good job diversifying the panel in this version of the guideline. We're talking about close to 70 panel members from 23 countries. Over a third of those have low-middle income country experience. Diversity in terms of specialties, including a larger proportion now of allied health compared to the past, and even diversity in terms of subspecialties clinically, including internal medicine, anesthesia, emergency, and even surgical background. Similar to the approaches used in the previous iterations of the Surviving Sepsis Campaign, there was a rigorous process for the declaration and the management of conflict of interest, included a dedicated group to adjudicate those conflict of interest, and a clear mechanism on how to manage conflict of interest, not only financial, but also academic or intellectual conflicts. So folks who are leading clinical trials in the field that are relevant to specific people questions, they were not allowed to vote on those questions to minimize the intellectual bias when it comes to recommendation formulation. However, they were allowed to participate in enriching the discussion. This slide, although an oversimplification, it summarizes the journey of recommendation formulation in any grade-based guideline. The process starts from formulating the clinical question in the PICO format. These questions were not selected randomly. We followed a clear structure outlined in this slide, but in a nutshell, the selection of questions was following 3 main tracks. Questions has to be clinically important. They should address a clinical gap or a clinically important topic. And for those questions included in 2021 version of the guideline, they were all reviewed and adjudicated by the panel members. And then these questions, after they are prioritized within the subgroups, they're submitted to the leadership for finalization and approval. Following selection of the questions, obviously no question is complete without the outcomes. And again, outcomes were not just selected haphazardly. We followed the grade approach. So the panel member came up with a large list of outcomes, and they prioritized them according to the grade approach and retaining only critical outcomes. And when we say critical, we're talking from the patient perspective. And again, they were submitted to the leadership for finalization and approval. After finalizing the questions, for each question, we conducted a literature search. So you ask the question, and the second step is to look for the answers for these questions. While the time in this presentation doesn't allow us to go through details of search strategy, everything is included in the supplement of the guideline. However, for new questions that have not been addressed before in the guideline, a full-blown search without date restriction was conducted. For questions that have been addressed before but require update, we've searched the literature from the last search date and the previous iteration of the guideline. And on some occasions, where trustworthy guidelines exist, we adopted the searches and updated them as well. So far, we've asked the question, prioritized the outcome, we searched the literature. The next step is to summarize the evidence, or a process that we call meta-analysis. So if we were lucky and there are updated systematic reviews with meta-analyses that meet our eligibility criteria and they're of high quality, we just use the results from those reviews. However, in situations where high quality meta-analyses are not existing, we actually performed de novo meta-analyses to summarize the results. And the process of doing that was consistent throughout the guideline working group. Once we have the estimates for evidence summaries from meta-analyses, then the next step is to ask ourselves how confident we are about these estimates, or a process we call assessing the certainty of evidence, and we used the grade approach. Just a quick refresher about the grade approach. Grade treats evidence based from RCTs and observational study at the start differently, where evidence based from RCTs start at high and from observational body of evidence starts at low. But that's not necessarily the case after ending the assessment of the certainty of evidence. So let's take, for example, a body of evidence based on randomized controlled trial. Yes, we start at high certainty at the beginning of grade assessment. However, based on several other factors outlined in the right hand side of the slide, including risk of bias, inconsistency, and others, the confidence or the certainty of evidence could change. So if we had issues with risk of bias, the certainty of evidence could be downgraded to moderate. And if we add to that issues with indirectness, we could further downgrade the evidence to low, or even very low if there are like serious indirectness, like using literature from non-critically ill population, for example. So this way, grade allows us to move based on the certain components of grade and change the certainty accordingly. On the other hand, if you look at a body of evidence from observational studies, as we said, it starts at low. However, sometimes, rarely, you could upgrade the quality of evidence. So for instance, if you have a very large treatment effect, your confidence in the estimate could be increased, but these are rare occasions and not very common. What we have done differently and more systematically in this guideline is including the minimally important difference threshold. And I'm sorry this slide is busy, and you can find it in the supplement of the guideline. For each of the critical outcomes that I told you we've prioritized, we have established as a group, based on a dedicated survey, the minimally important difference that required for clinical effect. But we also defined the moderate and large effect also ranges, which helped us streamline the grade assessment of the body of evidence. Great. So after finishing the assessment of certainty of evidence, the next step is moving from evidence to decision, or evidence to recommendation. And again, we used a similar approach we used in the past, the evidence to decision framework, which I'm not going to go through into details. I'm just giving you a screenshot of a hypothetical example where these components, including the desirable and undesirable effect, the certainty of evidence, patient values and preferences, the balance between effect, the resources, costs, and cost effectiveness, equity, acceptability, and feasibility. A lot of work has been put into this process, and it's very transparent, and now you can look up those tables in the supplement and know exactly how the panel reached to these conclusions, because every decision is captured and presented specifically for readers. The next is the panel discussion and the voting process. So after finalizing the evidence decision table within the individual groups, the recommendations were sent for voting to the full panel. Those who are not conflicted, so those, as I mentioned at the beginning, with intellectual conflict, are precluded from voting. And we required at least a 75% response rate and 80% agreement to say that the recommendation have passed. We allowed for up to 3 rounds for each consensus approach or voting approach. However, for questions that were carried over from the previous iteration of the guideline, so questions that did not require updated search, that we felt the evidence is sufficient, they went under a single rounding vote only. And there were a 2-day in-person meeting to discuss those recommendations before finalization. And I think I've been involved this for a very long time, and I don't think we've ever achieved a very high consensus rate, and this speaks of the dedication of the leadership of this guideline and a tremendous amount of work. Still, you can't achieve a high or 100% agreement, but this is pretty high. And just quickly in the last few slides, I'm going to walk you through some terminology. So strong recommendations, which indicate clear, unequivocal benefit or harm, and are usually based on high moderate certainty evidence, start with the wording "we recommend." We've departed from using weak recommendations. Now we call them conditional recommendations to be consistent with the current grade approach guidance. And these statements usually start with "we suggest." For good practice statement, that we used to call them best practice statements. They have specific criteria we're following. And also you may find statements called "in our practice statements," and I would like to emphasize that these are not recommendations, and I'm going to explain them in the next few slides. So when the desirable consequences, for example, clearly outweigh the undesirable consequences, or vice versa, usually we end up with strong recommendations. However, when these consequences are slightly favoring one approach or the other, then we end up with a conditional or weak recommendation. And these have different implications at stakeholder level. One of the major problems that I found is the lack of understanding of the distinction between a strong and a weak recommendation. People, they default, once hearing the word recommendation, that these are strong by default, and that's not accurate. So for stakeholders like patients and families, almost all of them would like the intervention or to take that approach if it's a strong recommendation, as opposed to conditional recommendation, where many would want an intervention, however, substantial proportion wouldn't. Similarly, for clinicians, you have to think twice before not applying a strong recommendation. However, for conditional recommendations, typically require shared decision-making, and they may be subject to values or preferences. For policymakers, most strong recommendation could serve as policies and performance measures. However, for weak recommendation or conditional recommendations, it's less appropriate. For researchers, it's probably better to direct resources to help answer questions that are on conditional recommendation, as opposed to those with strong evidence-based and strong recommendations. So please pay attention, because in our practice statement could be misunderstood as recommendations, but in reality they are not. So in situations where recommendations were not feasible because the evidence is not there, or it's of very low quality or very low certainty, that the panel could not issue a recommendation. we surveyed the panel, since we have a large group of experts from around the world, and asked them how they practice. So it's merely just a descriptive descriptive statements about the variability in practice. So they are not recommendations, they are not graded, they were not formally voted on, they should not be guiding policy, and in fact, they are just to show variability of practice, and they should be only hypothesis generating. As for carryover statements, although no formal literature search were done, we did identify, review those statements, verified and formalized the wording, and we also asked for one round of voting by the full panel as well before finalizing. This was my last slide. Lastly, I would like to thank the patient representatives who've helped support the guideline development and weigh in on certain aspects, and also thank the fantastic panel who have done the hard work, and the methods team, and also my methods co-lead, Dr. Morton Highlander Muller, and the guideline chairs, and would like to thank you all for your attention.
So thank you, Walid, and it's time now to move on to the core of the guidelines, which is indeed a discussion of what is new and what may be different from the previous iteration. And for that, it's my real pleasure to welcome on the podium the two co-chairs, Ali Prescott for SCCM and Massimo Antonelli for ESICM.
Great. Well, thank you, Daniel. It is my distinct honor to be here presenting on the new and revised Surviving Sepsis Campaign recommendations. I've listed disclosures for me and Massimo here. And I'd like to just acknowledge and thank my panel. So we are here presenting on behalf of 69 panelists from 23 different countries. As Walid mentioned, this is a very diverse panel. 38% currently are previously practicing in low and middle income countries, and 35% from outside Europe or North America. And also I'd like to thank our staff partners, as well as the patient and family members. So as Walid mentioned, very important to understand implications of strong and conditional recommendations. And so this table is included right in the main guidelines, previously had been in the supplement, or I think may have been missed. We also recognize that it's difficult to diagnose sepsis in real time. Often when patients first show up to your emergency department or come into your intensive care unit, you may be uncertain about whether they have sepsis or a different acute illness. And so we have used standardized terminology throughout the guideline for definite, probable, possible, or unlikely sepsis. All right, so without further ado, we will get into the core of the guidelines content. So there are 129 statements, so these are quite comprehensive guidelines. As Walid mentioned, we did something new this time, which was to do those carryover statements. So that was basically just acknowledging that statements from prior guidelines are still accurate and relevant today, but based on our panel's expert knowledge, we felt it was very unlikely that there would be sufficient new evidence to warrant a change in recommendation or a change in the strength of that recommendation. And so to prioritize our resources to answer new questions, we adopted this process where we did a one-time vote to say, yes, this is still accurate and relevant to practice today, we will continue it. Those are listed in the guideline, but they don't include a narrative, and they did not undergo a formal updated evidence synthesis. That allowed us to prioritize our resources to address new questions, many questions not addressed in prior guidelines. So in total, among these 129 statements, they address screening and early management, infection, hemodynamic management, respiratory support, adjunctive or additional therapies for sepsis, goals of care, transitions of care across care settings, and then long-term outcomes. The majority, about 64% of the guideline is conditional or weak recommendations. We also have 17 strong recommendations, 19 good practice statements, and 11 statements of insufficient evidence that should be considered as research priorities going forward. So what is new? So as mentioned, we really tried to answer new questions not addressed in prior guidelines, and in total, 46 of the statements are addressing new questions not addressed previously. And so we don't have time to go over all 46, but we will cover some of what we think are sort of higher priority recommendations to discuss. So the first one, this is recommendation number 3, for acutely ill patients en route to hospital via ambulance or flight, we suggest using a standard sepsis screening tool. So this, really follows up on the keynote earlier this morning by Tex, talking about the importance of moving our recognition and treatment of sepsis outside the hospital walls. And so based on our review of the evidence, the balance of effects really favors pre-hospital screening for sepsis as patients are en route to the hospital. The next new recommendation we'll highlight is number 21. This is for adults with definite or probable sepsis and hypotension, and who have a prolonged transport time to the hospital such that it's anticipated they will not have an in-hospital medical evaluation for over an hour. We suggest initiating antimicrobial therapy in ambulance or flight en route to hospital. So I'd like to just really highlight that this is a targeted recommendation for people who both have sepsis and hypotension and prolonged transport time. This is not to be, misinterpreted as recommending antibiotics for every single person in the ambulance. At all times, we are trying to balance timely treatment of sepsis, but also recognizing the importance of antimicrobial stewardship. We also include a remark with this recommendation that pre-hospital antibiotic delivery should be implemented only after that structured process to screen for sepsis in ambulance and flight, as mentioned in the prior recommendation, has been implemented. All right, next new recommendations we'll highlight relate to mean arterial blood pressure targets. In the prior guidelines, there was a recommendation to target 65 or higher, but there was no kind of upper limit placed on that. And sometimes in practice, we see that patients remain on vasopressors despite substantially higher than a 65 MAP. And so we have revised this slightly to say that we recommend an initial MAP target of 60 over higher targets. And we have a remark acknowledging that it's not feasible to maintain MAP exactly at one number. There needs to be some range around that, and so that we should aim for a reasonable range around 5 millimeters mercury surrounding this target. We additionally have a new conditional recommendation that's very specific to older patients. So patients with septic shock ages 65 and older, we suggest using a lower range surrounding that target of 60 to 65 to minimize vasopressor exposure in this population. All right. Next new recommendations we'll highlight relate to the empiric antimicrobial therapy, and this is a paired two conditional recommendations together. So conditional recommendations against and for use of empiric anti-anaerobic coverage. So we suggest using this in patients at high risk for an anaerobic infection, but minimizing and withholding anaerobic coverage in many patients with sepsis who do not have risk for an anaerobic infection. So these pairs of recommendations acknowledge that many patients who present with sepsis get quite broad spectrum antibiotics, but particularly for certain types of infection like lung infection or urinary tract infection, very unlikely that that is being caused by an anaerobic pathogen. But covering patients with anti-anaerobic coverage contributes to microbiome depletion and worse longer-term outcome, increased risk for secondary infections. And so we recommend tailoring that empiric therapy and trying to withhold coverage of anaerobic pathogens, particularly at sites of infection where it's exceedingly unlikely that that's going to be the cause. So this means both, avoiding prescribing things like metronidazole or clindamycin that are specifically, prescribed to target anaerobic pathogens, but it also means being mindful of the antibiotics that we select for gram-negative coverage, such as piperacillin tazobactam, which, part and parcel with the coverage of gram-negatives comes very, heavy coverage of anaerobic pathogens. So trying to be mindful of what is coming along with the empiric regimen that you are prescribing and matching that to your patient risk factors. All right, next recommendation, this is number 41. This is for mechanically ventilated patients. We suggest using selective decontamination of the digestive tract, or SDD. This is a approach that has been around for a long time, and there are many clinical trials, but it really has not been addressed in guidelines before, and I think has limited use in practice. This approach uses topical, oropharyngeal, and intravenous antibiotics, very specifically targeted to gram-negatives and actually not targeting these anaerobic, sort of healthy gut microbiomes. So it kind of relates to the prior recommendation, and that this strategy, while it does include antibiotics, is about preserving, healthy gut microbiome. And in the balance of evidence, this is associated with reductions in mortality and also possible reductions in multi-drug resistance. All right, the last recommendation that I'll cover before passing over to Massimo is a new suggestion, a conditional recommendation to use active fluid removal after the acute resuscitation phase has passed. This is trying to promote a sort of a neutral fluid balance and avoid fluid overload that we know is associated with worse outcomes. And so with that, I will pass it over to my co-chair, Professor Massimo Antonelli.
First, please let's express the senses of my gratitude to the entire panel and my co-chair that for the 2 years work, intense and really fantastic, a very nice experience. What has changed since 2021? 3 statements have been changed, just adapting, abridging the rationale for statements that are different from the 2021. Okay. Sorry. Okay. The first recommendation we look at with this approach was against the use of empirical antifungal therapy as a conditional recommendation with low certainty of evidence. But the remark opened a door for a judicious application of the antifungal therapy. Even though the recommendation is against, there are situations where the possibility of using in empirical therapy also the antifungal therapy should be taken into consideration, such as the immunosuppressive patients, those who have a prolonged use of antibiotics, prolonged hospitalization, and intra-abdominal infections. Not easy. For the adults with septic shock, we suggest to use either invasive or non-invasive blood pressure monitoring. The conditional recommendation with very low certainty of evidence, but we couldn't reach, looking at the evidences in the literature, a clear-cut recommendation in favor or against one of the 2 methodology. The only consideration that we may add in the remark is that probably you can use the invasive monitoring when you have to monitor the high dose of vasopressors. We have to escalate the dose of vasopressor, or when there is the need of a frequent and repeated arterial blood gas sampling, or when there are discrepancies concerning the various methodology over time. For the volume replacement therapy, the crystalloids alone are certainly suggested and are in favor of the recommendation over the crystalloid with supplemental albumin. You may remember that during the previous iteration, this was open an important discussion. And in this case, the only remark that may at least taken into consideration the supplemental albumin, and when the patient has already received large crystalloid volumes, or in the case of they do have cirrhosis. But this is clearly underscored that supplemental albumin should be carefully avoided when the patient has a brain injury. What is changed? There are another additional 8 statements for which the guidance is consistent with 2021, but certainty of evidence, 6 of them, and another 2 had a change in terms of strength of recommendation or certainty of evidence. The first of the 2 that has been upgraded from the conditional to strong recommendation is the use of prolonged infusion of beta-lactams antibiotics for the maintenance over a bolus administration. And the other one was the de-escalation antimicrobial therapy in sepsis, where the de-escalation is recommended over the no de-escalation at all. You have to consider that the de-escalation consists in the discontinuing unnecessary antibiotics when you have the pattern of susceptibility that is broader than the antibiotic that you are using at the moment. And also this was upgraded from the conditional to strong recommendation. There were 44 statements that directly carried over, as has been mentioned before by Heli. 39 revisited PICOs yielded 7 unchanged recommendations and 29 recommendations with revised wording or new remarks. This was kept the same, but as you may notice, it's a good practice statement that sepsis and septic shock are medical emergencies. Then the treatment and resuscitation should be given immediately. It's interesting, however, to stress again that the timing of antimicrobial therapy may be different depending upon if the sepsis is definite or probable or a possible when the shock is present. In this case, you not have to hesitate and you have to give the antibiotic immediately. And even you have the sepsis definite or probable, and even in absence of shock, you have to give immediately the antibiotic. The only exception that allows a margin of time is when the sepsis is only possible and the shock is absent. In this case, we are allowed to postpone a little bit the antibiotic administration within 3 hours. For the adults with sepsis-induced hyperperfusion and septic shock, the suggestion is to give the 30 ml per kilogram body weight of intravenous crystalloid within the first 3 hours. In the remark, is stressed how may be important, however, individualize to the patient characteristics. For example, those who have cardiac failure may not tolerate such a huge amount of volume since the very beginning, or when you prescribe, you need to be very careful not under or over resuscitate your patient. And the weight-based fluid volume should be calculated on the actual body weight, as well as the adjusted. And in case you have a large BMI, over 30 kilograms per square meter, you may use the ideal body weight. At the edge of evidence, several PICO questions have low certainty of evidence in our practice. These are situations where we have a sort of window in the future research, maybe. These are part of unmet situ conditions that probably will receive the dignity of further research in the future. I want to spend just a few seconds on this slide because this is the figure of the hemodynamic management, which is divided in two different parts. The first, that what you have to do when you have a deep hypotension and the elevated lactate. In terms of monitoring, within 1 hour, you have to measure the lactate or use the capillary filling time test. The fluids should be given within the 3 hours in the amount that has been already shown in the previous slide, and use always the balanced solutions, such as the ringer lactate. In terms of the use of vasoactive agents, if the patient is hypotensive, the first line agent is the norepinephrine. Then you can add the vasopressin in case the dose should be very high, and you have to target the mean arterial pressure to 60, 65, as Haley has explained you before. If the hypotension and lactate elevation persists after the initial resuscitation, then you have to reassess and at least use the dynamic tests in order to qualify the need of additional fluids, for instance. And you have always to look at the trend of lactate and the capillary refilling time over time. The problem of giving other fluid should be clearly based on fluid responsiveness, using always balanced solutions. Then you have to initiate a norepinephrine together with the vasopressin, and as third agent you may also use angiotensin II, even though it is very low certainty of evidence. And you can add the dobutamine in case there is also a cardiac insufficiency. I stop here. Of course, as Ellie said, we cannot summarize in such a short time such a huge number of recommendations. We tried our best, and we leave the stall to the other speaker.
So just to reiterate one thing, our first speaker could not get here because of world events. Massimo and Hallie and Daniel all flew here from Europe. Hallie might not feel like she's from Europe, but she flew here from Europe. So everybody came a long way here, except for me. I took an hour to get here. And Mervyn took 48 hours to get here from South Africa. So our final speaker, Mervyn Mayer, is truly an expert in working in low-resource settings. And he's going to speak to us about the applicability of the Surviving Sepsis campaign to low and middle-income countries. And we're not going to have time for questions afterwards, so before Daniel closes the session, after Mervyn speaks, I just want to remind everybody that the speakers will be available afterwards to continue the conversation after the session's over.
Thank you very much, Craig, for that very kind introduction. It's an absolute honor to be here. I'd like to express my gratitude to the supporting societies and Surviving Sepsis Campaign Guideline, to the beautiful and wonderful members of this panel. I don't have any disclosures other than some of the images I'm going to share with you have appropriate approvals. And this is an outline that we're going to run through. I'm going to give you some context in terms of why this is relevant. We're going to look at some fast facts related to sepsis in low middle income countries, look at the real reality, evaluate the Surviving Sepsis campaign right up to the 2026 guidelines, touch on some of the recommendations that have been made, some of which have been shared already, and look very briefly at other recommendations and resources. And then finally, we'll wrap it up with some personal insights and approach and some concluding remarks. There's no question of doubt that sepsis is a global health priority. We heard about that in a very eloquent session this morning. So much so that the World Health Organization put forward two resolutions, one in 2017, one in 2023, to improve sepsis care, improve emergency, critical, and operative care. And this is on a background of understanding that there's a major disproportion globally with respect to sepsis. 85% of the world's population live in low-middle income countries, and 85% of all sepsis occurs in those regions, as well as most deaths. Sadly, many of these deaths are potentially preventable. Dramatic new numbers being shared in terms of the prevalence of sepsis, with approximately 1 in 3 people in the world succumbing to sepsis, the highest burdens being in sub-Saharan Africa, Southeast Asia, and South Asia. And most clinical trials have been performed in high-income countries, and one of the concerns is, can you extrapolate that into the low-middle income setting? We see a different pathogen and patient profile. We see tuberculosis, we see malaria, we see parasitic diseases, we see dengue, we see tropical infections, we see HIV-associated infections, in addition to the common bacterial, viral, and fungal infections. And the patient profile is entirely different as well. In fact, we see younger patients, many of them who have comorbid diseases as well, malnutrition, chronic anemia. And this is a map of the global differences in terms of those pathogens. There are massive and multifaceted barriers to sepsis care, diagnostic limitations, infrastructure limitations, and the pictures you see here, the bottom right-hand corner there, demonstrating a simple institution. And in fact, the picture above, my own institution, overburdened in an urban setting that cannot often support the elements. We have limited critical care capacity. In some countries in Africa, there's 1 bed in ICU per million population. We are precarious and sometimes no water, electricity, and oxygen supplies. Often a lack of equipment, both functional and adequate, limited support services, and by that I mean radiology, operating theaters, human resources and skills which are limited, and often an absolute paucity of medication and massive financial constraints. And I want you to focus on the point below. There's a 20-fold difference in annual spend per capita on healthcare in high-income countries versus low-income countries. In Africa alone, less than 2% of the average spending in high-income countries. And look at a country like Madagascar, the 4th biggest island in the world, spending $17 annually per capita. That is 350-odd-fold less than a high-income country. This is often compounded by late and delayed presentations, and public awareness is extremely poor. In fact, a survey in Brazil relatively recently demonstrated that just 7% of people had ever heard of the term sepsis, and following a campaign that was doubled to 14% over a 3-year period. 75% of deaths from pneumonia, meningitis, and other infections occur in low-middle income countries, and where facilities exist, ICU-acquired infections are far greater. In fact, device-associated infections 5-fold higher versus US ICUs, and a recent systematic review revealed that healthcare-associated infections across low-middle income countries affected about 1 in 4 patients, and close to 40% of patients in low-income countries. Massive rates of antimicrobial resistance, the epicenter being in sub-Saharan Africa, huge problems with antimicrobial stewardship, limited post-sepsis care facilities, and life expectancy hugely different. If you look at Nigeria in 2026, you can expect to live to 54 years of age. In Monaco, it's close to 90. And these are the elements that we really need to be cognizant of when we put together guidelines, when we look at the contextual issues. This table, recently published in Critical Care Medicine, in fact, goes through the elements in more extensive detail. This is the reality of what we see every single day. Necrotizing skin and soft tissue infections, a patient with cancrum oris requiring resection of half his face. Perforated hollow viscous issues with open abdomens in the left lower portion. Severe tuberculosis, the middle picture on the bottom. amoebic liver abscesses with drainage, and mpox. These are all patients in my own setting that have occurred just in the last few weeks. A complication from a peripheral IV line with necrotizing fasciitis requiring ablation of the limb. And severe meningococcemia, resulting in bilateral ablations of lower and upper limbs. And in low middle income countries, we have an absolute paucity of rehabilitation facilities. This is a huge problem. Severe varicella pneumonia with an X-ray that looks like this. And this, a case of capnocytophagic anemosis following a dog bite requiring ablation because of late presentation. And so on that background, the fabulous Surviving Sepsis Campaign guidelines were born following the Barcelona Declaration in 2002, and we're now sharing the 6th adult iteration in 2026. But across this issue, people have always questioned, are these guidelines applicable and feasible for low-middle income countries? And if we go through the evolution of things, it's been described as fitting a square peg into a round hole. That was in 2011. In fact, a survey evaluating knowledge and implementation revealed poor knowledge and implementation in 2013. And in 2016, the whole issue was relooked again. And then, thanks to ESICM, SCCM, and Surviving Sepsis Campaign guideline leadership, we were given a 5-minute presentation period to address these issues. And so we moved to the 2021 guidelines, which stated in the introduction that they largely apply to high-resource settings, but the discussion of applicability to low-middle-income settings was there. And so evolution had begun, and very well done to the leadership of that particular group. There was greater panel diversity, greater emphasis on clinical acumen and judgment, increased number of references pertinent to low-middle-income countries, and where feasible, suggestion that these could be adapted. So that brings us to the 2026 guidelines. As already mentioned, broad geographic diversity, close to 40% of the people having had exposure in low and middle income countries. Each subgroup had at least one panelist practicing in low and middle income country. In the group that I had the privilege of being able to be involved with, there were 4 people endorsed by 25 societies, many of whom represent or based in low-middle income countries. And every single recommendation that you heard shared today was looked at for its universal applicability, and the comments in the narrative similarly. The standardized language makes for massive improvements in low and middle income countries, and the figures shared are applicable or adaptable to low middle income countries. The in our practice component further adds to this. It's relevant to daily practice universally. And the actual process was inclusive, engaging, enthusiastic, effulgent, exceptional, with committed and focused interactions, with the total aim of providing excellent guidance for everyone. So I'm going to run through some select recommendations. Some are carryovers, some are revisits, and some are new to give you a total perspective. And I think the most important one up front carried over is that sepsis and septic shock are medical emergencies applicable wherever we might reside. The pre-hospital screening things have been alluded to improve the timeliness of sepsis care. And a new recommendation that I love is the Code Sepsis or Sepsis Huddle protocols, multidisciplinary teams that can expedite sepsis diagnosis and treatment possible in all settings. Comprehensive evaluation of antimicrobial therapy with attention to antimicrobial stewardship as well. Who, when, what, how, the duration, de-escalation, and importantly and often forgotten, source control. We showed you those pictures earlier with the revisit suggesting earlier rather than late in a 6-hour time frame being given. Very important for low middle income countries, often forgotten. We've been through the antibiotic timing and this excellent, explicit, and very simple directive. In terms of blood pressure monitoring, sorry, I'd like to just go back one. We've touched on the mean arterial blood pressure targets and the implementation of a range around this initial 65 millimeter target range, hugely relevant. It's impossible. We don't have the staffing to follow and monitor specifically 65 millimeters of mercury. And the element for older patients, very useful as well, although there is limited evidence in low and middle income countries. From a diagnostic perspective, another recommendation I really love is that of the blood cultures, and this is recommended, in other words, strong, for possible, probable, or definite septic shock as soon as feasible, and ideally before the administration of antimicrobial therapy to get the greatest yield. In fact, if you have septic shock, your yield is in excess of 50%. And in fact, the guideline gives brilliant guidance on the number of sites, number of sets, the collection volume, whether we should use anaerobic bottles, and who requires repeat cultures. And this is particularly applicable, and there's guidance for low middle income countries. We now know that one site is adequate, one set of cultures, 10 moles of blood, and anaerobic cultures are not necessary unless you're worried about that. And there's direction for Staph aureus, Staph lugdunensis, and Candida species for repeat cultures to see that there's clearance. And then another lovely addition suggesting and reminding people to take cultures from other sites if relevant. The fluids have been addressed, and in fact, this has always been a contentious and controversial issue with respect to the 30 moles per kilo, at least in the first 3 hours, and I think the new added remarks that Massimo alluded to are absolutely fabulous, and I would summarize that now saying we now have offered guidance for focused fluid administration. I think that's what it is. In terms of vasopressors, timing has been addressed. In other words, early vasopressors or later, and one should initiate fluids initially, follow with the vasopressors unless you're in dire trouble. The route peripheral, very useful in the low middle income setting, and the type of vasopressor, although norepinephrine is regarded as the standard drug of choice, it's not available in many low and middle income countries, and epinephrine can replace that. In terms of blood pressure monitoring, fabulous, invasive or non-invasive, and I think this is a major potential advancement in terms of the non-invasive one, and has been reiterated with the EVIDAC randomized clinical trial published following the recommendations were finalized, demonstrating non-inferiority. I love capillary refill times and have been advocating it for many years. They suggest it as an adjunct measure of perfusion. It's feasible, it's reproducible, it's readily implementable in all settings, and in fact, the most recent Andromeda 2 shock randomized controlled trial, again published following completion of the guidelines, reiterates that issue. In fact, it was better than usual care when used to guide resuscitation. Dynamic measures to guide fluid resuscitation. We don't have stroke volumes. We don't have SVVs readily available to us. But we can all check pulse pressure, the difference between systolic and diastolic pressure. Look for the variation following a fluid challenge or a straight leg raise test. Measure it non-invasively, and you in fact have the same result, perhaps not quite as accurate. I do that every single day, easily performed in low resource settings. And in terms of monitoring of hypoxemia, massive advance. We could use pulse oximetry if arterial blood gases are not available, and similarly we can use SpO2 FiO2 ratios to substitute for PaO2 FiO2 ratios. The guidelines suggest that there may be some cautionary notes. Working in Africa, we've been doing this for years and we don't actually see a major problem from a pragmatic perspective. Awake proning, which costs absolutely nothing, has been suggested, extrapolated from COVID data in patients with acute hypoxemic respiratory failure. And I would actually suggest you don't have to turn the patients on their tummy and exhaust them, just get them to sit up or stand. The lungs are a triangle, you'll get better expansion in that setting. Intravenous corticosteroids touched on, widespread availability, not costly, and in fact, meta-analysis done for these guidelines revealed a mortality reduction, both short and long term. In terms of stress ulceration prophylaxis, for patients with risks for major GI bleeding, proton pump inhibitors are advocated as first line, but new issues is that H2 receptor antagonists are a reasonable alternative, making this feasible in all settings. And antipyretics, a new recommendation, a suggestion against its use for improving clinical outcomes with considerations based on their use in different clinical settings, for example, pain control, patient symptom relief, neurocritical care. In terms of transitions of care, the good practice statements advocating for education of primary care providers and post-critical illness follow-up services. This may vary in low middle income countries, but the advocacy is excellent and very welcome, and we should always be aspiring into and striving for more and having something in our armamentarium where we can say a guideline actually suggests the following, and similarly for physical rehabilitation. The hemodynamic recommendations have been touched on, and I'll just say these are adaptable in all low middle income settings. Where lactates are not available, you can use capillary refill time. Where you don't have norepinephrine, epinephrine, in fact, can be used. There are other recommendations and resources out there to complement these issues. They're the 8 recommendation evidence-based papers from the ESICM Global Intensive Care Group based on efficacy, safety, feasibility, and cost. And this is available both in terms of each particular module, as well as in book form that has been downloaded 170,000 times. There's a global Delphi expert consensus statement looking at low and middle income countries, resource-limited areas, really excellent document. And more recently, the sepsis chain of survival, applicable everywhere, has been published. There's also a commentary looking at what one could do in very sparsely resourced setting, using the Vilfredo-Pareto principle, taking the least number of things that make the major difference in patients. And then there are contemporary commentaries on these topics. So what are the issues we can take out? We are often told that the challenges are so significant in low and middle income countries that it is pointless even trying to move things forward. In fact, recent commentaries in excellent literature, The Lancet, for example, one of the commentaries recently was dying in the dark if you have critical care and you're in a low middle income country. Another called decay abysmal, another said it was rudimentary. Challenges present opportunities, and being in a poor environment or in a resource-poor setting is not equivalent to poor care. In fact, excellent quality care is feasible and absolutely possible. We are often told to do more with less, but we should never compromise patient care by doing less for more. And if you do the simple things well, as exemplified in this guideline, you're likely to have a successful outcome. Clinical acumen should always be incorporated into whatever we do. And I'm often told we're wasting our time, it's impossible. And the optimists say, well, you know, nothing is impossible, so let's try. I like to take that term and turn it around. Impossible is nothing. If you have the focus and the will to want to do things, and this guideline has helped us move it forward. All of this should be done with the spirit of Ubuntu, which is a wonderful South African and African philosophy, encompassing care, compassion, and humaneness in everything that we do. And so as the sun sets on this talk and this session, this is a Johannesburg sunset taken from our own home a short while ago. We've been through the challenges and some of the solutions, and what I've highlighted here is that the 2026 Surviving Sepsis Campaign guidelines are excellent. They're a great advance, and they've significantly and positively built on the earlier inclusive approach with the aim of conferring outstanding sepsis care for all, wherever we are in the world. They, in fact, bring forward excellence in sepsis care, with a universal approach, and they will favorably impact many, many lives. Every sepsis victim in the world deserves that chance. The leadership, and two people sitting adjacent to me here, have been incredible, sublime. I regard them as sagacious, wise people who absolutely are inspiration. They've done a phenomenal job, as have everyone involved in this guideline, support staff, all the panel members. It's been a brilliant exercise. So my hearty congratulations, a very gracious thank you. And we can definitely move this forward. This is, in fact, a slide from Hallie and Massimo shared 1 year ago. It takes a great team to build the SSC guidelines, and I think you're entirely correct. I'm going to finish off with just some seminal thoughts. I've been fortunate enough to have grown up in a country where I was exposed to Nelson Mandela, someone who taught us about challenges and how we can, in fact, overcome them. And I'm going to share two quotations which resonate very deeply with me. And this is one I think we all need to take out. What counts in life is not the mere fact that we have lived. It is what difference we have made to the lives of others that will determine the significance of the life that we lead. And a second quotation, which I think puts everything into perspective with respect to this guideline. He had the following to say: it's in your hands to make a difference. And I don't know if anyone wants to complete that quotation. To make this world a better place for all who live in it. And that is what we are all gathered here today about. Listen to the words. That clip was not going to play, but thank you very, very much. It's been an honor, a privilege, an absolute delight, and I feel very humbled to be within your presence, within this great group of people, and I'm sure that these guidelines, which in fact are applicable to low middle income countries, are going to make a huge difference. Very gracious, thank you.
Thank you very much. This puts this session to an end. I think that these guidelines will be very useful for patients in high-income countries, but also we have here also sometimes middle resource in some places, and these aspects also will be covered there. So these guidelines will be published right now in our respective journals, the critical care medicine and intensive care medicine. And also, for those interested, do not forget that we have a session beginning in a few minutes for the children guidelines. Thank you very much.